Hi, this is Abby Johnson. I am an assistant professor in physical medicine and rehabilitation at University of Michigan, and I am a rehab psychologist, neuropsychologist.
I'm Jennifer Mendez, and I'm from Wayne State University School of Medicine. I'm an assistant professor there, and I direct our community engagement programs.
So I know Kay gave you all a heads up that today is going to run a little bit differently. I'm going to start today by just orienting you to some of the definitions we use. The focus of today's module in today's seminar is really multidisciplinary practice, interdisciplinary practice, and interprofessional teams. So we're going to start by doing some definitions, and then we're going to talk about the case that you were all sent. And we will have you present your information, and Jenny's going to give you a little bit more information about the structure of that as we move forward. Our focus is really having a productive discussion around these things, so if that takes the whole time, great. We'll like that, and we'll discuss both the case and also some reactions to the case today. And if we have time, we do have a little bit more information for you that will come across in the PowerPoint, and if we have time today, we'll touch on it. So the World Health Organization has defined interprofessional collaborative practice, and you'll see the acronym IPC in some of our documentation and certainly throughout the LEND curriculum. What IPC is when multiple health workers from different professional backgrounds are all working together for patients, families, caregivers, and the communities that they live in. And this really is felt to be the way to deliver the highest quality of care. So that was defined by the World Health Organization. In order to do interprofessional collaborative practice, we need to have interprofessional team-based care. And so their definition of team-based care is care delivered by an intentionally created, usually small, work group in healthcare who are recognized by others and by themselves as having a collective identity and shared responsibility for a patient group. So this is an identified team, and it can take many forms. Things like a palliative care team, a primary care team, or a rapid response team. Another concept came out of some of this discussion that's called interprofessionality. And the idea here, I have the long definition up there, which I won't read to you. But the main key idea is that this is a paradigm shift in professional practice. As early as you start training, it's important to recognize that the days of practicing as a lone provider are long gone. And so the mission, and there's been a professional consensus group working together to develop a standard of practice for interprofessional care and interprofessional learning, because what's necessary is to teach people at all phases of their education how to work in these teams, how to build these skills so that they're ready for this interprofessional practice when they enter practice. So we wanted to get a sense from you about what kinds of interprofessional practice and interprofessional experience you've already had even as mentees. So this is an opportunity for folks to raise their hand and share with us some experiences that you're already coming into this discussion with in terms of interprofessional collaborative care.
Hi everyone. So at the medical school, Dr. Mendez set up a program, the Interprofessional Team Visit Program, and all second-year medical students participate. So I had my visit, and we went to an older person's home, and we did it with various professions. So I did my visit with a social work student and then also an occupational therapy student.
Molly, can you give an example of what you did as part of your visit and what your team members did?
Yeah, so my part of the visit, I gave the older person an eye exam and then went through various aspects of eye health, and I also did a nutritional assessment. And then the social work student looked at their relationships and their support systems that they have. And then the occupational therapy student looked at various aspects of their house, analyzing it was a safe environment, if there were indications to prevent, if they were at a fall risk. So things like, you know, having a railway or a handle by their front door. So it was really interesting to get to see what those professions would do, and yeah, it was very interesting because my older adults had never had any interprofessional care. So I thought that was very interesting that she had never really had, you know, her physician, her pharmacist, her social worker, anything like that work together to benefit her care.
And as a provider, how did that visit feel different in terms of your management of your patient with those other providers there?
I thought that it was more efficient, and I got to see more of a whole picture. I think if it was just me, I feel like there's gaps that maybe you don't think to ask about certain questions. So I think learning from, you know, their questionnaires and things that they wanted to know, I just got to see more of a whole picture. So I feel like you'd better be able to provide the best care to really know the whole situation.
Absolutely. It sounds like you had more information to use in your diagnostic formulation. Thanks, Molly. Other comments?
Yeah, I guess the place that I think about using the most collaboration with other individuals is when I'm on the inpatient unit, inpatient psychiatric unit.
Of course.
So we work with case managers, psychologists, there's educational specialists if it's a child unit, the techs, the nurses, us in psychiatry, you know, we do, I guess, a variety of that. On the adult unit, a lot of times they will bring in internal medicine physicians, and we'll have a team meeting that involves them, at least initially, if there's any medical concerns too, which is helpful.
So you have, in your team meeting, are all the professionals there?
Yes.
And are you making your diagnostic decisions as a group, or is somebody leading that team? How does that work?
Yep, usually as a fellow, we're kind of responsible for leading that team on the child inpatient unit. So the whole group kind of sits around, and we start by kind of talking about what we feel like is going on and what our disposition is for the patient. If we have any questions or concerns, then everyone else can kind of put in their input. Sometimes we'll talk about discharge and those types of things too.
Erica, do you have family or the patient involved?
The patient and family aren't in those team meetings. We have separate team meetings that, like during a discharge time, where the social worker and the educational specialist and myself usually are present for like a discharge meeting where we go through some of this stuff as a team.
Thank you.
Hi, everybody. I just want to piggyback on Erica's comments. I also work in an inpatient unit and work within a multidisciplinary team as a rehabilitation psychologist. And we meet weekly and discuss cases that are in the unit. And the energy that's created and the issues that are discussed a lot of times are intertwined. So, for instance, there might be behavioral issues getting in the way of PT and OT assessment, which is very important, or even speech. So when you hear comments from other providers and what's getting in the way of their work, it helps you build treatment goals for your own work. And then your own input about the psyche or the behavioral dispositions, either prior to becoming an inpatient or during the inpatient, could be very helpful in helping other providers do their work more efficiently, and most importantly, it leads to better benefit for the patient.
Absolutely. Thanks, Ramsey. I think what you and Erica are both touching on is this idea, that's the third point on our slide here, that really getting optimal healthcare outcomes in a variety of different ways changes when you bring in the whole team. When you're gathering information from multiple professionals, you get a more complete conceptualization of what's going on and of the patient. And then, just as the example you gave, you know, a behavioral problem that's affecting an assessment of a different specialty, like a psychological problem that's affecting an occupational therapy evaluation, you're getting good clinical information for your treatment of a patient as a psychologist by hearing from the OT their perception of what's happening. At the same time, using a psychological intervention is going to give the occupational therapist a much cleaner observation of what the patient's true capacity is. And so it works both ways to improve optimal healthcare outcomes.
Okay, well, we're going to now take you into a virtual team discussion. So we had developed some treatment goals and a basic treatment plan for Jenny, and our discussion will move around each team where they are going to ask their own team members and the parents questions. Each of the 9 trainees were given a role to play which wasn't from their own discipline. We selected disciplines for them that they're probably not too familiar with, so they had to spend a little time researching what questions that team member would have asked if that team member was part of this. We have a couple ground rules that we asked them, and that was they should not get out of character. They would stay in the character. Example, if the person was given the role of a physician but is really a social worker, the person who's playing the role of a physician stays in the role of a physician. They need to be respectful in their communication. So if there's a disagreement, go through the process of asking more questions in order to come up with a consensus of the whole team. Each team has been told that they have approximately 3 minutes to discuss their questions with their team or to be asking us others on this webinar questions. Our focus areas for them to think about was the impact of conducting an assessment as part of a team, and what does that have the impact on the team, the patient, and other members of the team or the family. Additionally, they had to identify factors that determine successful functioning of a team. Example, disagreement, questioning, when and where things would happen.
So Ramsey and Erica both mentioned that many of you have experience in treatment teams. What we're asking you to do is, this is a treatment team for our fictional patient. Some of you have had interactions in your small groups already. None of you have had a chance to discuss Janie's case as a whole group yet. And so today we want you to work together to identify 3 main treatment recommendations as a team for Janie and make a plan for how you're going to discuss this with her family. And then also identify what are the 3 main questions or clarifications that you're seeking from the family in order to help further guide your treatment with her. So in your roles, or as a group, we're going to open this up for presentation and discussion, and we're going to give you a good chunk of time here, so it's okay if it takes a majority of the time, but we'll have you move forward and come to a consensus on these key things.
I'm going to read out the case. The trainees have seen this, but for others on this webinar. Jenny is a 10-year-old with diagnosis of ASD and intellectual disability, goes to her doctor for concerns of stomachache and wave complaint of illness. She has a history of seizures that has been difficult to control, but stable for the past 6 months. She goes to school with the assistance of an aide because of her risk of seizures and her difficulty with communication. So whoever was the psychologist, speech pathologist here, would you start us off? And if you want, maybe the next one was the medical student, and then we have a psychologist on this one.
And actually, if you wouldn't mind, just when you start talking, identify what your role is, just so that everybody's clear.
Okay, I just have a quick question. I'm not sure, are we just asking the questions that we prepared for the PowerPoint slide, or?
Yes.
Yep, these are what we have posted here are the ones that you prepared, and I think if you have other questions that you would ask of the team or that you would use in this team meeting, that's allowed as well, but these are the starter questions. that we asked you to think about.
Okay, so I'll start since I'm at the top of the PowerPoint. I'm Molly, and I was the speech pathologist. So a question that I would want to ask the parent, I can also read you my just 2 sentences that I was given in additional to the case is that Janie works with the speech pathologist to improve her articulation and control her voice, and that the mom has expressed concerns about swallowing and her picky eating habits. So a question I would have for her mom is to ask what are her goals for Janie's articulation and communication. I think I need to understand her goals before coming up with a specific plan. And then my questions to my team members was, besides the diagnosis of ASD and intellectual disability, if there was any other pertinent medical history that I should be aware of.
Okay, and then I'm Alyssa, and I was assigned the medical student role, and based on the variety of issues for the stomach as well as seizure, I had the question for the parent, would you describe what Janie's diet currently looks like throughout a typical day, and whether any particular foods seem to precede the stomach issues that she reports? And then for the team, I would ask what type of testing has been completed by the speech pathologist as well as others, including the psychologist, to determine Janie's level and forms of communication in her school, home, and community settings.
So Molly, as a speech pathologist, can you respond back to Alyssa?
Yeah, so I looked into certain areas of testing. Things that I would do would be to look at the development and how these symptoms progressed, and also look at the strength and movement of the muscles involved with swallowing. I'd also want to do observe a feeding to see Janie's posture, behavior, and oral movements during eating and drinking. And additionally, I'd want to know if she was really picky or if there was some underlying cause, such as why she couldn't eat solids or liquids. And special tests that might have been performed is a modified barium swallow, which is where the child would eat or drink food or liquid with barium in it, and then the swallowing process would be viewed on an X-ray, or use an endoscopy assessment, which is a lighted scope inserted through the nose, and then observe the child swallowing on a screen.
Great. Alyssa, you were the medical student, and Molly, as a speech pathologist, has asked what are the other pertinent medical history that she should be aware of. So what did you determine?
Well, I felt that the information we were given was pretty limited, so I guess I could just say what information I would have looked into. So I definitely look into the nutritional and diet components of the medical history, as well as her seizure history. And if it hadn't been completed before, I would have a neurological evaluation, including an EEG, to see if we see patterns and where we can go from there. But like I said, it's kind of limited to what medical history I was given.
We are asking Alyssa and Molly to take the role of, one of them take the role of the psychologist and speak on behalf of the questions related to parents, and the other the questions related to the team.
Okay, I can start with the parent question for the psychologist. So she stated, I understand that Janie has had some trouble with bullying at school. Do you feel as though there are any specific actions that her peers seem to use to intentionally trigger an aversive reaction from Janie? Are there specific learning situations that increase these behaviors from other students? And how does Janie react to the bullying from her classmates?
And then the psychologist question to the team is, my understanding is that Janie has a long history of difficulty with explaining her feelings. I understand that Janie is currently receiving ABA therapy. At this time, are any of her therapy goals focused on increasing emotional awareness and communication? And I guess my response as the speech pathologist to that would be based on whatever the mom's goals with the articulation. I would want to pinpoint areas to work on her articulation and communication with Janie, such as expressive language skills, receptive language skills, speech fluency or stuttering, social or pragmatic language, cognitive communication skills, and also education and empowerment of Janie's mom to best help her.
And I think I would just add briefly to that I'd make sure that there were no medical barriers to completing any of the communication or therapy goals.
Excellent. So you're both correct. There's a lot that's not known, and yet you have some nice working hypotheses and treatment goals. Anything else that you would add in your team for the treatment team, for the rest of the treatment team?
You mean other disciplines?
Well, before we move to some of the other disciplines that are going to talk, right, is there any, I guess, other comments that you would make in terms of your conceptualization for Janie, or other questions for team members? I think you've covered a lot.
Yeah. We'll move on.
Okay, so Team B is going to be up next, and we'll let you guys approach it however you feel most comfortable. On Team B, we have a physician, a teacher, and a rehabilitation engineer.
Michael, what role did you have?
I was given the role of rehabilitation engineer.
Perfect. Start.
I had no idea prior to this what this was, but my question to Janie's parents were what kind of assistive technologies have they used with Janie in the past other than what she's currently using, which is an iPad? And what kinds of issues or successes did she have with those other kinds of assistive technologies? And then my question to the team members was how are Janie's current motor skills, both gross motor and fine motor?
And what background were you given as the rehab engineer?
What I was told, wait 1 second, I was told that her speech intelligibility is low and she uses her iPad to help her communicate.
And Erica, what role did you play?
I played the role of the teacher. So my question to Janie's parents was about whether or not her experiences at home were similar to the difficulties that she was experiencing at school. So whether or not there was something in the school specifically that could be kind of creating some of these challenges for her that we maybe need to work on. And then my question to the team members were kind of what accommodations or alterations could we come up with that could potentially help her to become more successful at school.
Great. We have one person who's missing. Is anybody able to report for that person from your team?
Yeah, I think we had a little bit of discussion, so I can kind of talk about her questions to the parents, and then maybe you can talk about her questions to the team members. I know that she had talked about the question to the parents is kind of indicating maybe how frequently she's having bowel movements, has she had problems with constipation in the past, to see if her abdominal pain maybe had something to do with that, and exploring that a little bit more.
And then the question that she had for the team members was, does Janie complain of belly pain during activities that she dislikes participating in? I think the reasoning behind it was perhaps she is trying to get out of doing work that she doesn't like to do.
Interesting. So before we move forward, I guess I want to pause and say, do you have anything to report to our previous Team A based on some of the things that you've heard from them?
And report to them, like about our kind of information?
Yeah, well, I guess I'm looking at, you've heard from a speech pathologist and a psychologist. I think you just brought a really good point up about potential avoidance of activity. So another thing I'll throw out to the group for discussion is Team A, do either of you want to raise your hands? Do you have a comment based on any of the information that you've heard from Team B?
And I guess I'm not sure if my kind of information as the teacher, I was given additional information that the school team had concerns of ADHD, poor concentration, frequently off task, behaviors, poor eye contact, not following directions, and ignoring others. So I think that's where some of this stuff came from with, is there something else going on? And I think with a little bit of the other additional pieces of information too, that we were maybe cued into, maybe there's some avoidance or some, dislike with the bullying and things too. So maybe that's where the psychologist could come in too.
Good point. Forward to Team C.
Okay. I can go ahead and start. I was assigned the role of audiologist. And my question to team members would be, how does Janie communicate her wants and needs at home and in the classroom? And has she tried other forms of communication, such as PEC? It's kind of what I want to ask both the parents and the team members, because the additional information I was given was that Janie has poor attention in the classroom and poor performance on a hearing evaluation. Mom has frustration at home related to Janie not following directions, not orienting to her name, and ignoring others. So I kind of just want to get a feel on how she's communicating her wants and needs, and that might go ahead and tell me how I can help test her or how I can help figure out her listening needs.
So Ramsey?
So the additional information that I got was, as a patient care attendant, I spend a lot of time with Janie. I help her with physical navigation, riding the bus, give her scheduled medications. And my goal with her is just to promote more independence and just to be there as an aid. Janie, from my experience, she is very social. She likes to socialize and talk more than engage in schoolwork. She can be somewhat combative and avoidant when engaging in activities that are not inherently stimulating for her. And she tends to have difficulties with reading social cues and the pragmatics of social situations. So as a patient care attendant, I wanted to ask the parent, what have they found helpful at home when redirecting Janie to tasks that are not enjoyable for her, to kind of help me use some of those strategies. And for the team, I wanted their collective input in helping develop a behavioral or intervention plan that can promote greater collaboration and consistency between school staff and her parents, because Janie does respond well to structure and consistency, and when things change, that's when sometimes I see her acting.
Excellent. Is anybody able to report for Zara as the social worker today from Team C?
Oh yeah, I can read her questions for you. She wants to know if she's asked about a possible FM system for hearing support, because that can help with attentiveness. And that, I'm not sure that question that's for the parents was the one that she provided for me. So I'm going to pull up the previous slide and see if that's different.
Okay.
Thanks for that.
Ramsey, meanwhile, while she's doing that, what are some of your comments to the other Team A and Team B?
I think we're hitting on a theme that communication could be a source of difficulty for her. So if we try to, when thinking about possible treatment goals, what additional strategies can we use to promote better communication or develop better communication skills for Janie if, since she's using the iPad as a primary source of improving communication and she's still having these issues, are there other strategies that we can implement to have her communicate her needs effectively?
Okay. Hannah, do you have the other section?
Yeah. Zara also wanted to ask what resources are available in the elementary school for children with autism and intellectual disability. Again, playing off that theme of what else can we do to help her communicate her wants and needs.
Excellent. Any comments that you guys would share? Or Hannah, Ramsey just said some, but Hannah, anything that you would add for Team A or Team B since you've heard them report at this point?
Just going back to that speech pathologist and the rehabilitation engineer, is how successful is she with the iPad system, and could we use it in a more productive way?
Excellent. Thank you guys. These were wonderful team reports. Now this is
The other, do A and B have any questions for C?
I would just add that with iPad, I believe reading that she didn't use the device across her settings, so those skills are usually not going to generalize without teaching. I know this isn't my role directly as a medical student, but as someone who has worked with children on communication deficits, that would be something I would be worried about, that, you know, if we're only using the device at school, that might be why we're seeing a lot of troubles in other settings.
Thank you. I'm just going to interject and please say your name when you start talking, just so that we know who's speaking up.
And what role you're speaking about.
That's a really good point. What I'm going to do is advance the slide here because what I want to do is open this up for a real discussion as a team. You've all reported your questions to one another as a team. And it's true that because you don't have Janie and her family here, and because Jenny and I have not given you any answers yet, there's more questions than there are answers. So let's take a few minutes here and prioritize as a team and come up with a strategy for how we'll build a treatment plan for Janie, knowing what we know right now.
And all 6 of you can speak, but please let us know who's speaking.
This is Alyssa. I'm just confused how we're developing a treatment plan if we don't have all the information. I don't know exactly what you're looking for, if we can clarify that a little bit.
Sure. So I think what you have is incomplete information, but everybody on the team has certain pieces that they've presented and certain pieces that they know. And so what we'd like you to try and figure out is what are the 3 main things that you would do next as a treatment team. And that can be asking questions, but we've come up with many more than 3 questions here. And then, so the first point is, what are your first recommendations of things that you would want to do to answer some of your questions? The second part is, how are you going to communicate this to the family? And then, because there are a lot of open questions, there's probably going to be some things that are not recommendations, but are clarification questions for the family. And so if if Jenny and I were the family, we're feeling pretty overwhelmed right now, and we'd like you to streamline it for us.
I think one of the main treatment things that I kept hearing as a theme is communication, ability for her to communicate and how we can kind of help her in that area. So I think that might be one of the main treatment goals, is how we can come up with a good or a better way for her to communicate.
If I can add, I mean, given that there is scant information but there's a lot of information that's spread out across the teams. And one thing that has come up is that we are still trying to understand whether some of the issues that she's facing with stomach aches and other medical issues that don't seem to be medically documented, and we're trying to understand whether those are behavioral. Maybe another good goal to have is to do possibly more evaluation to understand the context of her inconsistent behavior across settings.
This is Molly. Going off of that, as the speech pathologist, I would want to also know what medications she was on, as I know some seizure medications have a stomach ache or stomach upset as a side effect. So I don't know if it's behavioral or if it's something else or if it's just a side effect of the medication. So I guess finding the cause of the stomach problems.
How about the teacher? What are your concerns?
Did you say the teacher?
Yes.
Okay, so I'm Erica. I am the teacher. And did you mean like my concerns with her kind of behavior or functioning?
Right, and what you communicate, how would you communicate to the family?
So I mean, I guess kind of asking the question, I mean, and I did get a little bit more information just from the other team members as to like the aid and things, that her behavior at home seems to be quite difficult, especially around tasks and things related to things that she doesn't want to do. So whether, I mean, I guess my recommendation would be whether or not we can maybe implement some type of reward system, or, you know, whether or not I'm giving too much information or more complicated information than I should be giving for her level, or if there's, you know, other things that are factors there that should be looked at more, such as if she has ADHD, you know, should that be treated?
So Alyssa, as a psychologist, what would you respond back to our teacher here?
This is Alyssa. Did you say you wanted me to speak as Maddie for the psychologist role?
Yes.
Okay. My next step in this process would be to actually observe Janie in several different environments after medical rule-out was completed. So the teacher just made a point about what system she could put into place, and that would be determined by the function of her behavior. So if she was doing these types of things to escape activities, such as making stomach complaints, we would look at treating it based on escape, whereas if she was doing it to get the attention of her parents, teachers, or peers, we would have a different type of intervention. So I would definitely need to do a full functional behavior assessment as my next step.
Any other comments from team members about the main treatment goals or the main steps?
Yeah, I have a couple questions. As an audiologist, I would just like to know if the poor performance on her previous hearing evaluation is due to behavior during the appointment, or if it's actually because she has a hearing loss. And that could then clarify what our communication goals need to be, if we need to retest her to maybe see if she's not hearing anything instead of an attention disorder.
Excellent point. So I think the main themes that you're hitting on as a team, I'm just going to take a moment and summarize the key strategy that I think I'm hearing you report. It sounds like there's a need for more medical evaluation, and that's to try and determine a few different things. One being the possibility of seizure activity, or medication side effects, or her hearing loss versus other causes of her behavior. So a more comprehensive medical workup would be one of the first steps. One of the second steps would be understanding what her true communication skills are, and so that would involve a much more comprehensive assessment of her speech and language abilities, hearing, and also working with a rehab engineer to optimize her communication devices. But then there's this third goal of understanding her behavior versus her ability, and that's interrupting in the classroom and making it hard to tell what has she heard versus what has she not attended to or not heard, as well as what is she avoiding in class because of lack of motivation or other behavioral issues, as opposed to difficulty attending and communicating well. And so I would sort of summarize that as basically 3 different arms of treatment, one being medical, one being focused on communication, and the third being focused on identifying behavioral pieces. Am I hearing that right?
Yes.
Yeah, I think that's
I would agree. Yeah.
So how are you going to communicate this to the family?
I think, you know, as we've talked in previous weeks, the first step is really to align with the family and to let them know that you're hearing their concerns and that there are multiple team members that are trying to come up with a comprehensive approach to meeting Janie's needs. And then we can discuss, as we just reviewed, these initial treatment goals and see what their thoughts are on it.
And who's the we that we're talking about? I think that's an excellent point, that we want to ally with them and present to them.
So in Team C, Ramsey, who would take the role here to communicate this?
It could be either the psychologist or the social worker, or even yeah, I think those. I would say probably one of those two would be good team members to initiate the communication, but emphasize that there's an entire team working together.
Yeah, and I would agree that a social worker would be a good person to start out with, because they might get a more comprehensive picture of everything that's going on with Janie. They might know where to start.
That's a good point. Any other team members that you think would be important?
Yeah, I would think a physician as the primary person to see Janie would be a good person to talk to them about it as well, because they might have an understanding of Janie's overall needs.
Perfect. So it sounds like you've identified some kind of natural team leaders to present some of the overarching. How can some other team members help support this effort? For example, a rehab engineer, you might not be the first person to talk to the family, but how might you work towards these treatment goals with a family?
I think that talking with the other professionals and giving them a good idea of the things that I would say to the parents if I'm not going to be the person directly talking to them, and making it so that the person who is talking to them understands what my concerns were and what kind of explanations I would have, I guess.
Sure.
But if a physician doesn't know about a certain assistive technology and I just were to say, go tell them that we should use this one, the physician has no idea what I'm talking about, perhaps. I think it would be better if I took the time to explain why I'm picking that particular device and what that device looks like and what it does, so on and so forth, so that the physician isn't kind of going in blind.
Excellent point. So even if the whole team can't be there to communicate, it's really important that there's streamlined communication going into those conversations.
I want to know what the aide would do here, because the aide is spending so much time during the day with Jenny. So what would the aide be doing here to help the family and the teacher?
Yeah, I think as an aide, you know, I'm, you can say where the rubber meets the road, and I see similar challenges that the parents see. And what I can do is help facilitate communication as well, with just reporting what I'm seeing and given what the parents are seeing, and trying to understand from the parents what they are learning from other providers, what the plan is. And ultimately, I will just keep in touch to help create a consistent plan of and implement some of the interventions that will come out.
Absolutely. So kind of the last piece on here to try and address is, what do you need from the family at this stage? So we've laid out some basic arms of treatment, and we've identified that the social worker, the psychologist, and the physician may be our leaders of communicating that, but everyone has a role in supporting that. What do you need from the family right now?
This is Molly. I think one thing that's very important is to understand sort of their schedule. I don't know if Janie has a single mom or if both parents work, but possibly, you know, these office visits would have to take place, you know, after 5 p.m. if it's just Janie's mom. So I think understanding their schedule definitely plays a role into the treatment.
Good. Important. Anybody?
I think another thing that might be helpful is, you know, we all as a treatment team have our own kind of goals and what we feel are the issues and things that need to be worked on, but really kind of figuring out what the family's goals and their priorities are, because if they're not in line, that's gonna create problems too.
Absolutely. I'm going to advance the slide here. We've already been having this discussion. I had some prompts up still.
Well, at this point, we would like to hear from other members on this webinar. This is the point where we'd like the mentors to get involved.
Hello, this is Ed Hurwitz. Hi. So, you know, just listening through, I wanted to say that, you know, in my experience, it's always very important to understand, I heard some of this coming out in the themes, it's always very important to understand what medical problems might be contributing to behavioral and learning issues, and then what behavioral problems might be presenting themselves as medical problems. So one thing I really enjoyed hearing was how this interprofessional discussion, and this kind of thing we try to do, really brings out this point. You know, it's very easy to look at a patient. I see a lot of patients with chronic pain. Some of them have tethered cords and other reasons for actual pain, and some of them have family situations that contributes to chronic pain. And so there's always a real need to put everybody's head together and think about what's the best way to do this. The other thing I want to say is, you know, again, an interprofessional approach. You know, I was hearing, like, you know, be up to the rehab engineer to try and think about what's the best technology for this. And those of us who, you know, I know everybody here works with technology, and we know that really it's very much a team effort. Our augmented communication clinic, it's rehabilitation engineering, OT, and speech and language pathology, and the physical therapist often gets involved as I do. So it takes a team to do many of these things with the populations that we're talking about here.
Excellent point. Certainly team roles blend when you get true interprofessional practice going. So Ed mentioned some possible medical underlying causes. One that came up, or one that we put out there on purpose, is this idea of seizure medicine side effects for stomach aches versus a behavioral stomach ache complaint. What were some of the other kind of conflicting themes, or did anybody else have working hypotheses of what they think might be going on for Janie diagnostically? There were a lot of questions about attention and ADHD. Did anybody identify other possible things that were that could present that way?
It's given that she's 10 years old, I wonder about the way these problems have manifested over time. Is she in a setting now where it is more demanding than it has been before, and that could maybe she's coming into contact with things that exceed her coping and skill set.
So what behaviors might you see if that was going on?
It could very much look like distractibility, inattentiveness, and you can see escape behaviors as well.
Exactly. So we might be seeing some kind of escape or behavioral avoidance that's presenting as distractibility. There's another important rule out for her distractibility that one of our team members presented. Did anybody catch what that one was?
Erica, you had a comment?
Yeah, my comment was just about the kind of medical causes from before, so I didn't know if you wanted me to say that now or wait until she was done with her point.
Sure. We can go back to medical causes.
I think that the other medical causes that I was thinking about is I know she's on some anti-seizure medication, and I know that a lot of those medications can cause a lot of cognitive issues, and that can present a lot of times as inattention or being off task and not being able to focus just because of those particular medications, how they work.
Absolutely. So cognitive slowing or fatigue or physical discomfort related to side effects all could present as a decrease in your attention resources. So we could have something that really looks like an ADHD, but it's coming from a medical perspective. Our audiologist, I'm hoping, can comment on the other thing I'm thinking about.
Go ahead, Hannah. And please unmute your own microphone.
Oh, sorry. I muted myself on accident.
You're fine.
But as an audiologist, hearing loss can manifest itself as attention disorders. A mild hearing loss can cause a lot more effort to be put into listening. So if she even has like a mild form of hearing loss, it could be that she's not hearing as well as she used to, and so she's having to put more effort into hearing, and so by the end of the day, her behavior can decline.
Exactly right. So the overlap between inattention, hearing loss, and behavior because of lack of motivation or feeling overwhelmed or not coping well can be really hard to distinguish for patients. You add to that poor social skills, which is characteristic of someone diagnosed with an autism spectrum disorder, or impaired expressive language, which I know our speech pathologist talked about. It'd be important to know the nature of the speech-language problem. And all of a sudden, all of these things are overlapping really closely. Excellent. Any other comments discussion-wise? Things that folks noticed?
This is probably outside of my hat.
That's okay.
But, in line of the medical lens, her seizures were not properly controlled for some time, not until 6 months ago, and now they've achieved better control. But just because there's behaviorally and maybe even some neurological findings that show better control does not mean that there may have been decline given the poor control before. That could also manifest in these new, they're new onset difficulties.
Absolutely, and you've brought up two key things that we don't know for sure about Janie right now. She has had good seizure control for 6 months, but we don't know what her real profile was at the time that she obtained that good seizure control. The other thing is we don't actually know if she has good seizure control right now. Certainly, folks can have a period of stability and then break through seizures. And that goes back to that first medical question. we are mindful of time, and so we're going to shift gears in our discussion a little bit. I think everyone did an excellent job presenting within their roles. Everybody actually had to step up and also present for their team members, which is quite common in interprofessional care. So I think that was a unexpected extra bonus piece. But you've all had the opportunity to really step out of your comfort zone a little bit and conceptualize a case from a different point of view. I am very impressed that you've hit the key discussion points and the key conceptualization points that we were trying to lay out for you. We want to switch gears in our discussion now and take a step back and talk about this at the level of interprofessional practice and what this interprofessional, virtual, webinar-driven team discussion felt like.
So now we want you to go back into your own role as professionals and tell us your understanding of what you felt like when you had to change your role in this discussion, and what were your attitudes and feelings you had about working in an interprofessional team. This is a point where you talk to us about your own professional role and what you would have added to this case if you
I can share my reflection. My role as a rehabilitation psychologist and neuropsychologist, and then my role was a patient attendant. So in light of the Oscars, I really try to channel my inner acting skills. And I felt as a patient attendant that I needed help and I needed, answers, and but didn't have the expertise or the resources really to implement. So I felt somewhat at the mercy, I guess, of other professionals to give me direction.
Good point. The else on the team that had a role that they were not comfortable with. What did you have to search for online to answer these questions that we had thrown at you, since they were outside of your professional role?
I had to look up what a rehab engineer was in general. Prior to that, I thought it was a made-up role when I first heard it. So it was interesting seeing that there's actually a whole field out there that focuses on assistive technologies and how they can make them better specifically for the people that they're working with.
What did you find in terms of the qualifications for somebody in that role to get a job?
That was a little harder to find, actually, where there's no, like, you can't get a master's degree in, as far as I searched, you can't get a master's degree in rehabilitation engineering. You have to go through other avenues and kind of piece it together, as at least what I've found.
About speech pathologists. Molly, you had that role.
I was surprised when I looked into this exactly how much they do. I didn't realize how in-depth with the feeding. I just thought it was communication and more language skills. I didn't realize they did specialize in feeding and swallowing disorders.
I guess I found a lot of variability in terms of how you can become an aide. Certain positions require some certifications and trainings and like patient safety or confidentiality, and then there are others where you just need a high school diploma or a GED and you're willing to be trained. So there was quite a range, and given the responsibilities that they have, it's somewhat surprising that there's less structure in terms of what is required. And there was really no particular pathways when you're working with different populations, whether it's developmental disabilities or with the elderly. Anyone, I guess, can be an attendant. And the responsibilities are great. So that was, to me, that was the surprise, just to see how much they actually do hands-on that you don't normally think about when you make recommendations for a PA.
Alyssa, what about you?
As a medical student, I don't know what more you want me to, just my qualifications or?
What did you find out when you were trying to play the role of a medical student versus your own professional role?
Well, as a medical student, you can have a variety of specialties. So in my questions for the team and for the family, I kind of focused on a variety of information, including nutrition, seizures, because I didn't know which part, like neurology or dietary or anything like that. So a student usually ends up focusing their studies more toward the end of their education, but I wasn't exactly sure at which point they were in that role or what, so I just had a much more broad understanding.
What about your own professional role? If you were in that particular role for yourself in this case, what would you be feeling about this team that you had with you and the case itself?
So I spoke to that a little bit as actually when I spoke for Maddie as the psychologist because I am a behavior analyst, which is psychology. So in that role where I was speaking as that would be my feelings on the situation, but I know I've definitely worked on as part of an interdisciplinary team, and I think having all of these people present and willing to communicate with the family is essential.
Is that a challenge for you to stay sort of in your lane as the medical student versus the psychologist? I mean, I know we asked you to do both, but was it hard to kind of keep your psychology brain out of your medical conceptualization?
A little bit, but something I've found as a behavior analyst is that I always do a medical rule out first. So I rely on the medical professionals to do that initial step. So I tried to think of it as this is, the first step we're taking as the medical student, and later on I would go into the psychologist role. Because I've seen too many times where we haven't done, the hearing test or the medical rule out or the dental rule out, and that ends up causing a lot of the problem behaviors that we see, and we just didn't rule those out to start with.
Terrific. Erica, what about you?
So I think with the teacher, I feel like in my profession, I'm able to kind of talk with the teacher a bit, so I think that was helpful to bring that to the table. And then my, my mentor and I kind of came up with a little bit too. So I think kind of just putting myself in that particular role for this and looking at it from that view exclusively was kind of interesting. And I think that in my own profession, as a child psychiatrist and a fellow right now, I think it's very interesting to kind of see how this whole case kind of came together with all of the different teams and not having any information from what everybody else is doing or what kind of roles people are playing and all the support that they have. So I think putting that all together and kind of trying to figure out what information everybody else has and what you have that they don't know is almost like how it is every day. So I think that's interesting to see how that played out.
It's true. Every discussion you have in a team has information you know and all the information you don't know yet.
Well, I would like to move on and thank our trainees for this component of it. Now we're going to move on to ask our mentors what they see are advantages and challenges of working in a team, since this is something they probably have some experience with, and also what are the roles that they see for an efficient team and what kind of leadership roles are needed. You can go back to the case for Jenny or come up with something that you have experienced recently or in the past that our trainees could benefit from.
There's obviously lots of advantages of working in a team, and that people bring different perspectives and different skill sets to apply to helping a particular client. One of the challenges, though, is we oftentimes have different languages, different expectations, and different roles we have to talk about. And it really helps oftentimes to be real clear about idiosyncratic, profession-specific language that people are talking about. So that can help with kind of almost a glossary about how to talk about things so we're all agreeing to the same issues. The other thing that would be really helpful is moving down to the roles here and about leadership roles. One of the challenges of working with a multidisciplinary team is trying to get some consensus either on your assessment and case conceptualization or on your course of treatment and who's going to have which roles, and in particular how people are going to monitor progress. And people will have different profession-specific measures and expectations of clinical progress that can be shared with each other. And people also sometimes have different interventions that either facilitate or sometimes even interfere with another discipline's efforts to come up with some sort of an intervention. So all of those things need to be talked through in terms of getting consensus, understanding who has what role, who facilitates or potentially interferes with other disciplines, and in particular how all these different disciplines are going to collaborate together to monitor some sort of clinical progress.
This is Abby. I'm going to speak as a mentor for a second and just echo off of what Wayne was just sharing. You know, part of the challenge of finding a consistent communication and not stepping on each other's feet in terms of roles and interventions comes from having a leadership structure within your team. And one thing that I noticed in our mock here, in our virtual team, that I think is really, really common in real life is that the natural leader is unclear, and it's because we all bring leadership roles. So trying to find a direction for care and trying to come up with a focus and a consensus at the end of a meeting can be a real challenge. So I think having a communicator, a leader that can help move the direction forward is sometimes a really important thing to define when you have a team of experts.
I just, as Wayne said, you have to have consensus, and in terms of team members' expertise, their roles, and the different communication styles are important for us to keep in mind when you're trying to get the best out of your team for the family, for the child, and the next steps in terms of the treatment plan for the individual that you're caring for. Our next slide. So I think our goal here today was to demonstrate why interprofessional care is important. As some people have already reflected and brought up, there's a lot more complete understanding of a patient that you get when you're working in an interprofessional care team. It does get complicated to put together all of the information, and it does take extra time to make sure you're understanding what's being communicated. But, for example, each one of you had a limited view of where Jenny's problem or Danny's problem was coming from, and could easily have head down a different diagnostic path than would be appropriate. So that's one clear example of interprofessional care. This has actually been looked at widely, though, and there's been a consensus group that's examined why interprofessional care is important. And so we know pretty clearly there are advantages of conducting the assessment as part of a team. Your quality of care goes up. The safety of care for the patient goes up. However, redundancy will go down and the cost of care will go down. And I think our team A, B, and C very clearly demonstrated that when they were discussing their own roles as well as the role play that they had, how they would be able to provide better care for Jenny. The other advantages that we wanted to make sure that we communicate with you was the errors going down and fewer gaps in care, the improved communication between the team. As you saw from when they were playing their role, they were a little less open about what they would like to have happen versus when each team member spoke about it from their own profession. They were more open and able to share more of their own experiences for it. But as our team members or our trainees, focus was the person, which was Janie, as the center of their treatment plan, and they were all concerned about the satisfaction and the learning that her family would have, the teacher would have, the aide would get out of being a part of this team. Some of the competencies that across professions that we need to make sure we communicate with you are the values and ethics, as Wayne brought it up, and I think Ed brought that up as well, for interprofessional practice. Keeping your own ethical roles and your discipline-specific practice values is going to be your number one focus. Your next would be your own responsibility as that professional in the team, making sure the communication is clear and there's team and teamwork going on. In order to do that, we're going to go a little bit into some of the values and ethics for interprofessional practice.
Yeah, and I don't have a complete list up here, but what this is coming from, I'd be happy to share with anybody. We can put it up on Blackboard. This is the core competencies for interprofessional collaborative practice, and this was an expert panel group from 2011 when these were first laid out. And so what they did as a consensus team of experts was identify the kinds of competencies that should be focused on while professionals are still in training. And so that applies to all of you in this program. And there isn't a chapter to read on it, but what it is practicing and working with your mentors and working with your teams to understand how to use these values and ethics when you're working with other professionals. So I've just highlighted a few of them here, but it's valuing and intentionally valuing patients and populations as the center of care, intentionally creating respect and dignity and privacy for patients because team communication is complicated. We talk a lot about valuing cultural diversity and individual differences. And then a lot of the other three really talk about the values and ethics of a team. So working in cooperation with others, implicit in that is valuing the expertise of others and valuing their role within the team. Developing a trust relationship, and this has been a theme of many of the modules that have come before us, but that trust relationship has to exist at the level of patients, families, and other team members. And then there has to be a commitment to managing ethical dilemmas specific to interprofessional practice. So conflicts between caregivers and between professionals will happen, and they need to be managed. There are times when it will be tempting to work in opposition of a team goal as an individual provider, and so it's a value you have to maintain to be part of the team. Today that really didn't come up. Everybody was a very respectful team member today.
So in order to make sure that our team was open, we asked them to be receptive of what was being discussed, to display interest, which they all did. They were actively listening. I don't think I heard anyone using any jargons. So those were our ground rules that we had given our trainees, and they conveyed that very well as part of the exercise today.
And happens to fall right in line with the competencies for communication. Another set of competencies is knowing your role and your responsibility. And so our goal today was to test that a little bit by giving you a new role. Part of valuing working in a team is understanding not just what you can bring, but also what other people bring and what your responsibilities are, as well as what other responsibilities are. So you'll see there's a theme here with each of these points, but the idea being that you have to use the full scope of knowledge, skills, and abilities among your team. And so it's essential to a healthy team practice to respect and acknowledge when a different professional has a deeper set of skills than your own role. So an example of that is that there are often overlapping skill sets within teams. A common one that I run into as a psychologist is that speech pathology and psychology have some overlapping expertise areas in assessment and assessment of cognition. It's tempting to get into debates about whose role is what, but another way to recognize that is to have respect for the different scope of practice of assessment of both of those expertise areas and really understand how to get that full set of knowledge available to the patient who's the center of the care. So in Janie's example, really the behavioral and emotional assessment is something that the psychologist might have unique expertise on. Many aspects of the communication and some of the subtleties of expressive language versus receptive language versus more of an articulation communication problem would certainly fall more in the realm of speech pathology. And then there's a gray area in the middle where the two can come together. So understanding and respecting these things are core to interprofessional practice. And the last core set of competencies, and again, this isn't exhaustive, but this is just to give you a flavor for it, has to do with understanding how teams work. So up at the top there is something I mentioned a little bit earlier. The process of developing a team and defining roles and practices of effective teams is an important piece to healthy team development. Knowing how to engage other health professionals in shared patient-centered problem-solving skills, meaning it's important to work with one another around the same problem, and that might mean going as slowly as defining the language you're using for the purpose of the meeting to get around problems of different vocabularies or jargon. Applying leadership practices and understanding that in some teams you may be a defined leader, and in some teams there may be a hierarchy where you are not the defined leader, but you're collaborating with them in the spirit of clear communication. Shared accountability is another one that I think is important to highlight, and that professions, patients, and communities all share that accountability. So sometimes, especially on a pediatric team, we feel very responsible for all of the patient behaviors, and there sometimes can be a lack of recognition that the family and the patient themselves also share that responsibility and accountability with us. So understanding that the patient and the family are part of the team and how that dynamic works is another important one that I'll highlight. So like I said, we can share these core competencies with you in totality. And what we're going to do and what we'd like you to reflect on moving forward is the ways in which this plays out in your everyday clinic practices and how you can be mindful of your roles and responsibilities, your team work, your communication, and your values and ethics within the teams that you're already involved in.
And last but not least, the slide that our whole program for LEND is based on is leadership, interdisciplinary, family-centered care, and equity. And I think this case demonstrated this very well for you in roles that you played as leaders of the team or as members of the interdisciplinary team. Also for focusing your treatment options on the family-centered care and being of equity to everyone, not just to your team members, but to the family. And we'd like to say thank you for participating and being a member of the life considerations and the interprofessional module that we just presented to you. We're open to questions.
Yeah, nice set of materials, and I especially like the guidelines for teamwork. let me just add an observation about how challenging this can be. About 15 years ago, the Institute of Medicine produced a report called "To Err is Human," and it was all about medical errors that were supposedly contributing to about 90,000 unnecessary deaths per year. And to put that into perspective, that's essentially 300 deaths per day, like a 747 crashing every single day of the entire year just about. So it's a serious issue. And when they looked at the causes, the root causes of some of these medical errors, a significant portion of them had to do with interdisciplinary and inter-team communication, with people not doing a good job with handoffs or communicating when someone was about to give a wrong medication dosage, for example. And part of this has to do also with the very nature of some medical teams, where it sometimes is very hierarchical, with one person being the authority figure and other people sometimes being afraid to challenge the authority figure. So the reason I'm pointing that out is just to illustrate that while those guidelines sound fantastic, and they are fantastic, the real challenge is how do you put these into effect and get team members to be less territorial and more focused on how do they contribute to the benefit of the person that they're supposed to be serving, and how do they politely and tactfully raise concerns if someone else is doing something that might be not beneficial, or how do you make sure that people are following through on the full range of obligations. So it's just an observation that sometimes these things take a fair amount of application in practice. I have seen people use things like simulation-based training to improve team communication and reduce errors and improve kind of collaboration between members. So those are some things that might be thought through as people are taking these really good guidelines and beginning to apply them in their own context.
Absolutely. I'll echo that JCO has actually reported statistics that errors can be reduced by more than 70% with interprofessional communication structures in place. So it's something that when it can run well, you're absolutely right, can vastly reduce things like medical errors. The other part of this consensus statement that I think you're exactly touching on is that it takes teaching professionals at the level of education before they're even in practice to start to build recognition of the importance of a team and skills like listening and respecting team member roles. And so each one of you, if you haven't already, will have experiences where you're working with professionals who are very comfortable operating on their own and are not comfortable and not well trained at operating in a team. You're right, I don't have a magic practice solution for that other than, as you said, having these kinds of values and structures in mind, but knowing that it will take time and culture change, essentially, in order to start to foster these things.
I was impressed with two medical students at Wayne. This fall, they conducted the home visit, as Molly mentioned earlier, with an older adult, and a couple weeks ago came to me and asked if they could create scenarios that they could talk about handoffs and what happens in the emergency room, because that's another area of a lot of medical errors occurring. And they are currently writing up 2 cases that they will be using this summer to pilot between medicine, pharmacy, nursing, and PA students. So there'll be 4 disciplines in these scenarios, and they want to implement it for all year 3 medical students at Wayne. And so this was just one example of how you can impact by a small little program and get them thinking about other ways and means in which they can further the teamwork and roles and responsibilities as students or trainees in these programs.
Well, trainees worked really hard in our virtual team discussion today. This was a much more active role for them. So we are happy to give you the gift of time for the last half hour if there are no other questions or comments.
So we'd like to say thank you to everyone.
Thank you.
Be safe. Good night.